Welcome everyone to the Arthritis Foundation and American College of Rheumatology Research and Treatment Showcase. I am Nick Turkas and I will be your moderator today. We very much appreciate the Connect Group community tuning in for this very special presentation of an Arthritis Foundation webinar. We have an all-star cast of healthcare professionals, rheumatologists, and nurse practitioners to teach us about the latest and greatest research and treatments for arthritis. We're just going to give another minute or two for folks to get on, get comfortable, and we will start shortly. Again, thanks for joining us today with the Arthritis Foundation webinar. We will start in just a moment. Thanks everybody for coming to today's webinar. We're going to start in the next minute. Really appreciate everyone being here. Special thanks to our presenters. Special thanks to you for taking time to learn about your arthritis, emerging treatments, science, and also supporting the Arthritis Foundation. We really appreciate the American College of Rheumatology for their assistance in putting this webinar on and for the outstanding research that they do to help support patients. I'm going to go ahead and start the presentation. Hi, everyone. My name is Nick Turkas. I am the Senior Director of Health Promotions and Community Connections at the Arthritis Foundation. I'll be your presenter and mainly in the background today. I've been with Arthritis Foundation for more than 25 years, and I help oversee things like our webinars, our Connect groups, our live in-person events, and a physical activity program called Walk with Ease. I've been here for a long time, and I'm really excited about this particular presentation because we are bringing some of the best healthcare providers, researchers, and scientists to you, Connect Group community, to help inform you about all of the great emerging science. We have muted all of our attendees. We do have a Q&A function. We prefer that you use the Q&A function over the chat to help us answer questions. We will answer questions throughout the presentation, both in writing. We encourage all of our presenters to respond to questions that they are called to answer. But we will also have a Q&A session at the end of the presentation where we will get to lots and lots of your questions and answers. This is a special presentation of an Arthritis Foundation webinar. We have invited our Connect Group community to be the first to view and participate to ensure that they have a chance to ask their questions. These are some of our most engaged patients, and we really appreciate them being here and being part of our outstanding community. This will also be posted on the Arthritis Foundation's YouTube channel and on our webinars page. Please check it out for lots of upcoming events and outstanding past webinars. Today we have three main objectives. We want to understand new research from the American College of Rheumatology and especially their Convergence event. We want to learn about potential future improvements in arthritis, diagnosis and treatment, and discover Arthritis Foundation and College on Rheumatology resources. We have an all-star group of healthcare providers, of rheumatologists, and advanced registered nurse practitioners here today to share their knowledge. We have Dr. Erin Bauer, Dr. Arinola Dada, Dr. Kori, Dr. Gregory C. Gardner. Special thanks to him for help organizing this event. And we're still waiting on we have Dr. Singh is here, and we're so glad she is, and she will be on this presentation as well. We are covering a wide variety of topics today, everything from basic science, scleroderma, interstitial lung disease, gout, rheumatoid arthritis, psoriatic arthritis, lupus, pain, physical activity, and partnering with your healthcare provider. So lots of outstanding topics. And again, we'll answer all of your questions as well. And with that, I'm excited to bring to the stage Dr. Gregory Gardner, a rheumatologist and at the University of Washington. Dr. Gardner, thank you for being here today.
Well, thanks for helping us put this together, and we're excited to participate. Do I change slides myself, or you do that?
Call them out to me, please.
Okay. So let me tell you what Convergence is. So I'm actually the chair of the planning committee that puts together a once-a-year meeting called Convergence, where rheumatologists from all over the world come to the U.S., various cities, to gather to learn about the latest and greatest in advancements in treatment and research on diseases that cause things like lupus, rheumatoid arthritis, scleroderma, rheumatologic diseases. And people also get to network and think about new projects they can develop to help move the field forward and help people who have rheumatologic diseases. It's an exciting time. I've been a rheumatologist for 36 years, and it's hard for me to believe I've been a rheumatologist that long, but then I look in the mirror and see I'm no longer a spring chicken. And but during my career time, there's been some absolutely amazing advances in treatment of rheumatologic diseases. And many of those were first presented and actually probably thought about during Convergence. Next slide. So I'm going to tell you a little bit about some of the basic science, a little bit about scleroderma, and a little about interstitial lung disease. We'll be covering some topics we think you might be interested in that happened, that were discussed and updated at the Convergence, our national meeting. So first thing I'm going to tell you about is a really exciting area of basic science that has now emerged as a potentially very interesting treatment option for people with various rheumatologic diseases. I'll tell you about that in a second. So what is CAR therapy? It stands for, let's see, I got to get back here real quick. The actual CAR means chimeric antigen receptor cell. And what that means is that in a T cell, which is one of the major cells that helps fight infection and other sorts of things, scientists have been able to insert a protein that not only directs that cell to a certain target, but also activates the cell at the same time. It's been used in cancer chemotherapy for some time with excellent success. And now we're actually using it for people who have autoimmune disease. And they use T cells, and they're called CAR T cells. And they currently are targeted against other cells that make harmful antibodies. That's the focus of current CAR T therapy. And the diseases that have been looked at using CAR T therapy have been serious lupus, serious scleroderma, and serious myositis. And there's not been a large number of patients yet, but those patients that have been studied have had fairly dramatic improvements. And many of them go into remission, and many of them are off all medications as well. So stay tuned for CAR T therapy. We're hearing more about that every year. And as more and more patients get treated, we're actually starting a trial of CAR T therapy here in Seattle, where we're based, and looking forward to having some of my more severely affected patients be considered for therapy. It's not cheap. So it costs between $35,000 and $180,000. There are side effects, like all therapies we have, and we're not quite sure how long the good results will last. So again, we're in the very early stages of using CAR T therapy. So stay tuned. And again, you might ask your rheumatologist or rheumatology care professional, if you have difficult to treat disease, whether or not you might be a candidate for CAR T therapy. Next slide. This is how it's done. So let's go through the process here. So what's done is your blood is collected, your T cells are isolated from the rest of your cells. They are given a virus that inserts this CAR protein that both serves as a target and an activator for the cell into those T cells. Those CAR T cells are then expanded. You get therapy to make sure your disease doesn't flare as you come off all your other medications, and then you're given very strong medicines to suppress your other lymphocytes, your other white cells, and then you're given the CAR T infusion. So one of the things you can see that may be problematic here would be potential infection as one of the major side effects of this therapy. So, but again, this is an exciting advance, and the results so far have been really, really wonderful for some of these patients. But again, it's not done for mild disease. It's done for people who are not responding well to other therapies or have very serious, rapidly progressive disease. Next slide. Let's talk for a second just about scleroderma. So scleroderma is a relatively rare disease that causes hardening of the skin, can affect your heart, your lungs, and other organs. And we're now developing more and more therapies for this disease. But the other exciting thing that's happened over the last few years is identifying what are called biomarkers or antibodies made by disease-producing cells that help us identify potential forms of disease and potential manifestations of disease that help us direct therapies based on those markers. For example, I work in a clinic where we see lots of people with scleroderma who have lung disease, and that on that picture there where it says diffuse, that SCL70 is a marker that indicates that somebody who has scleroderma and has that antibody in their blood is at risk for developing interstitial lung disease. I saw a patient yesterday in clinic who has had what's called a U3 RMP, or I'm sorry, U1 RMP, and I'm worried about her, and we're changing her medications based on that biomarker, and hopefully will prevent some of the potential problems that are associated with that particular antibody in people's blood. So it's leading to more personalized care, helps us identify people with certain risks, and helps us potentially choose therapy that might address those, which is a really exciting advance for the field of scleroderma. Next slide. So in terms of therapies, I remember when I first started as a rheumatology fellow back in 1987, we didn't have hardly anything that treats scleroderma with, but now we've got some really exciting advances, including, as I mentioned, CAR T therapy. So mycophenolate is one of our major medications we use for scleroderma. It's also called Cellcept. Studies have shown that it can impact level of lung disease. It can help soften the skin, also help people who have muscle involvement from scleroderma. Methotrexate has a long-standing medication that you may be aware of. It's actually pretty good for skin disease and joint pain. Doesn't work so well for lung or for muscle disease. A newer agent called tocilizumab or Actimra has been approved over the last few years for lung disease. Rituximab, also a long-standing medication used for other diseases like rheumatoid arthritis, and before that, lymphomas, is been found to be good for lung and skin disease. IVIG, which is human antibodies that are infused into somebody in large amounts, can be useful for muscle disease that doesn't respond to other therapy. We try to avoid prednisone in scleroderma because higher doses of prednisone have been associated with rapidly developing blood pressure and kidney damage. So we try to avoid high dose prednisone, but occasional low doses of prednisone can be helpful to alleviate some symptoms like joint pain and swelling. There's also stem cell transplant, which has been around for a while, and that has been shown to help many aspects of the disease. It's even more expensive than CAR T therapy and has more risks. For people with very serious scleroderma that's progressing rapidly, stem cell transplant can be very useful for, again, selected patients. Next slide. So we're going to talk about lung diseases now. And rheumatoid arthritis is a disease in which about 10% of people can develop a lung disease. The one that I take care of and research is interstitial lung disease, which we'll talk more about. Infections are more common in RA patients because of lung disease that may be there, but also medications that suppress the immune system. Rheumatoid arthritis patients can get large airway disease that may affect breathing, and airways may actually be up into the neck that may cause, again, difficulty with swallowing, difficulty with breathing. Rheumatoid nodules are not uncommon in people with rheumatoid arthritis, and also pleurisy is more common. Luckily, in rheumatoid nodules and pleurisy and airway disease are much less common than they used to be because of our highly effective therapies. As it turns out, the interstitial lung disease continues in spite of the good therapies we've had over the last 30 or 40 years. Next slide. So we'll talk about interstitial lung disease. What is interstitial lung disease? So it's inflammation in the lungs that causes lungs to scar. It usually affects the lower levels of the lungs and may be made worse by things like heartburn or reflux, as it's known. The symptoms of interstitial lung disease are shortness of breath with activity. And I'll ask my patients with rheumatoid arthritis, do you have trouble going upstairs more so than you used to? Or how about climbing hills? Is that a more difficult activity for you than it was a year or so ago? As the disease progresses, people may get short of breath at rest. And also another common symptom is persistent cough that you may blame on a recent cold you had, but can certainly be a sign that you might have some interstitial lung disease. We make the diagnosis by breathing tests, by CT scans and occasionally by lung biopsy. And there are certain treatments we can use that we select if you have rheumatoid arthritis associated interstitial lung disease, and also some medications that might help prevent scar formation. Next slide. So I mentioned about 10% of people with rheumatoid arthritis can get rheumatoid arthritis associated interstitial lung disease. It's more common in men. If you have a history of smoking, it's more common. Most people with RAILD are those with high levels of rheumatoid biomarkers like CCP or rheumatoid factor, and there are certain genes that also increase the risk. There are some medications that have been found to be useful at stabilizing the lungs and improving inflammation. I will point out the fact that once you develop lung scar tissue, we don't get that back. So once we recognize that you have interstitial lung disease, we want to be able to intervene as quickly as possible, prevent more inflammation causing more scar tissue. So there's a medication called abatacept or Orencia that has been found useful along with rituximab. And then there's a medication called nintedanib or Ofev that may help prevent scarring. We do know when I was just a youngster and a fellow in rheumatology, we were all worried about methotrexate as a cause of lung inflammation. As it turns out, it was guilt by association because 10% of people with RA, as I mentioned, get interstitial lung disease. So because it was such a high number, people thought methotrexate was the cause of that. As it turns out, methotrexate is not as bad as we thought it was back then. But nonetheless, it's not our favorite medication to use if somebody has RA-ILD. In isolation, we often add another medication to the regimen. All right, next slide. And then finally, there's a lot of exciting research being done in the field of interstitial lung diseases. They're developing new ways of preventing fibrosis. And there's what presented at the meeting was saracatinib. I had to practice how to pronounce that word several times. It actually blocks a chemical called TGF beta. And TGF beta is a very important chemical or cytokine in the blood that helps promote scar tissue and so-called fibrosis. And there is human trials that are currently ongoing, but the results haven't been reported yet. But it's exciting to know that there's some new areas of research and some almost to market medications that might help us as ILD physicians help prevent further disease. And then finally, there's a brand new medication that's still in early phases of research called PNA 33. It doesn't even actually have a name yet, that affects cells called macrophages. And this new therapy seems very promising as well as preventing and actually potentially reversing lung fibrosis. So what I want to leave you with is the fact that this is an exciting time because of all the great research that's being done and our understanding of diseases. And again, hopefully we can do this again in the future and to report to you even some more exciting results from some of the studies that are being done currently. So I'll leave it there and turn it over to, I think it's Arinola, right? Dr. Dada?
Yes.
Yes, thank you, Dr. Dada. We're excited for you to talk about gout today.
Okay. Well, thank you. Thank you, Greg, for that very informative talk. There's so much exciting things going on in the world of rheumatology. Thank you, Nick and Nija, for inviting me. And yes, I am excited to talk about gout and the latest and greatest things that are happening in that world. I'm a rheumatologist, and just to really reinforce Greg's maturity, I was a fellow under Greg a long, long, long time ago. And he taught me everything I know. So you can blame him. But I'm a rheumatologist, been practicing for 20 years in the greater Seattle area. And I'm excited to talk to you today about the interesting things surrounding gout. And so for those who don't know anything about gout, lucky you, because gout tends to be a very painful disease. And so gout's a condition that is caused by high levels of uric acid in the blood, and this uric acid can form dagger-shaped crystals that can get into your joint, and that's usually when most people realize that they do have gout. But the interesting thing, which we're going to talk about today a little bit, is that it's not just your joints. It could be blood vessels, it could be prostate, and it could be associated with a lot of other things that are not just diet, because everybody thinks, well, stop drinking beer and stop eating shellfish. There is much more to that, and there's some genes that could be related. So we will go to the first slide. Thanks. Okay, perfect. So one question that patients have asked over the years is, hey, Dr. Dada, you keep telling me that I need to lose some weight because if I lose some weight, my gout will be better controlled. But what happens to me between here and there? If I'm 300 pounds and I'm losing muscle mass, doesn't muscle break down to purines and purines break down to uric acid? Will that make my gout attacks more before I get to the desired 150 pounds? So this was an interesting study that looked over 5 years at people, whether they lost 5% body mass, 10%, that every little bit of weight that they lost was associated with a lower likelihood of having an attack. And so a lot of times patients are concerned about the fact, well, because nobody likes to have a gout attack, I can tell you that. And so it was really reassuring that even through the process of weight loss, people had fewer attacks. So one, please do go ahead and work on losing the weight. Two, you're not going to have more attacks when you do that. And even the smallest amount of weight, in the next slide, even the smallest amount of weight was still associated with a lower incidence of gout attacks. So I feel that was very reassuring to patients who are kind of dealing with their metabolic profile, weight loss, and gout attacks. And we can go to the next slide. This was very interesting and surprising to me. So I thought, let's talk about this. So we talked about the fact that gout is due to people having high uric acid levels in the blood. But a note of caution, not everybody with high uric acid in the blood will develop gout. So the uric acid actually has to form crystals and settle in different parts of the body, especially the joint, for it to be called gout. It has to be in the joint causing problems, then you have gout. So the studies show that people can generate uric acid and gout inside the prostate. And so the question was, well, is it just the uric acid level being high in the blood that can be associated with prostate cancer, or is it having the uric acid in the prostate? Well, so they looked at genetic testing. And so they found out that some genes are associated with how the body metabolizes uric acid, and some genes are associated with inflammation. And it appears that the genes that are associated with inflammation, so inflammation in the prostate, inflammation in the joints, were more likely to be associated with the risk of prostate cancer. So in summary, they found that a certain gene, for instance, to get into the theory of it, was a gene that involved the IL-1 pathway, which causes inflammation, was high in these patients that also had both gout and had prostate cancer. So it appears that the inflammation is a problem, not really the uric acid on its own. So when the uric acid sits in the organ, it creates an inflammatory process. And that inflammatory process is what increases the risk of prostate cancer. So it appears that potentially, if we can control that inflammation, whether it's in the prostate, then perhaps we can lower the likelihood of prostate cancer that's associated with this increased uric acid deposition in the prostate. So it's the inflammation, not necessarily the blood uric acid. So that was actually news to me. And so I thought I should share this because this may be coming in future as one of the things that people are looking at when they're looking at people who have gout and prostate cancer and how they can potentially address or prevent it. Next slide, please. Thank you. And this is my final slide, and it goes again to the systemic effect of gout and high uric acid. So this study looked at the carotid arteries. So that's the blood vessels that takes blood to the brain. And so those vessels are very important because if we have plaque buildup, I think people know that's cholesterol buildup, and that gets inflamed, it can flick off and go into the brain and cause damage. So this study looked at a number of patients and did an ultrasound test, and they wanted to find out if the inflammation in the carotids marked the inflammation in the joints that people with gout were experiencing. So what they found was that if we were able to treat the whole body inflammation, so we're able to treat the inflammation in the joints and also treat the inflammation in the plaque, which is the blood vessels in the carotids, if we did both, then the plaque would actually shrink over time. But if we did not, if we left the inflammation and we just treated the uric acid alone, but we did not treat the fact that the patient was experiencing a lot of inflammation, the plaque size would stay the same. So inflammation was a problem, not necessarily just the blood uric acid. So it means that if a person has gout and we're saying, okay, we're just treating the gout, we should also look for whether or not the person has high cholesterol or whether or not the person has other things that kind of go hand in hand with that metabolic syndrome that we do know is associated with gout. So lesson here is for your doctor, when you have gout, your doctor is looking at the whole picture. It's your blood pressure, it's your cholesterol, it's making sure your kidneys are working fine and making sure your weight is under control. So it's the whole body we look at, and gout is just one of those things that's also a risk factor for coronary artery disease and metabolic syndrome. So these, I think, are kind of three interesting topics that were gout adjacent, but hopefully informative for our audience, and looking forward to any questions that they may have later. Thank you.
Thank you so much. Now we have Dr. Namrata Singh.
Good afternoon and good evening, wherever you might be tuning in from. Thank you so much, first of all, Naja and Nick, for the invitation to present. And the two topics that have been assigned were rheumatoid arthritis and psoriatic arthritis, and some updates from last year's ACR. You know, these are very heavy topics in the sense a lot is covered on them at the ACR meetings most of the times, several sessions. So it had to be boiled down to very few things. And so because I also knew Dr. Gardner is presenting and how much he loves the lungs, I took the approach of going with the heart for some of my topics. And having said that, maybe next slide, thank you. So the first one I wanted to talk about is rheumatoid arthritis and heart. And I think at the end of this, between what between by so far two already have presented, I think you are already appreciating that most of our diseases in rheumatology are not just joints, right? Like we talk about rheumatology, the science and study of joint diseases, but all our diseases transcend systems. So rheumatoid arthritis and heart health is my first topic in rheumatoid arthritis. And one of the main studies that came out in 2022, I'm not sure how much you might be aware of. It's called the Oral Surveillance Trial. And it really was a trial where they took patients who were they were cherry picked because they were at a higher risk of cardiovascular events. So something like myocardial infarction, stroke, etc. And we know patients with rheumatoid because of this inflammation, and, you know, building on the theme that Dr. Dada has already said about bad inflammation is bad for you. So inflammation is a risk factor for heart disease as well. Patients with rheumatoid have heart disease. So they looked at specifically the second and third bullet on the slide, the treatment drugs called JAK inhibitors and TNF inhibitors, and they compared the two of them. Specifically, the JAK inhibitor drug was Xeljanz, which is the brand name, which is tofacitinib, and TNF inhibitors, either it was the adalimumab, which is Humira, or Enbrel, which is etanercept in some patients. And they compared them head to head and found that patients who had taken Xeljanz, that arm had higher heart disease risk at the end of the 4 years of follow-up, which was very concerning, right? So if you are a patient of mine and we discussed this trial, of course, I'm going to be like, is this a drug that we should continue on anymore, given the light that this trial shed? But the reason I'm bringing you now, why am I talking about something in 2022 and 25, is this post hoc analysis. So they went back in the trial. They were looking at different aspects of the trial. One of them was the first bullet here, statin. So I'm sure, you've had some discussions. Some patients in the audience might have had discussion of whether you should be on a statin for your cholesterol lowering or not. And what this trial was doing after the fact, they were analyzing, okay, remember I said these are patients, they were already at higher risk of cardiovascular disease, such as heart attacks. So ideally, you should be on a statin if you're at a higher risk. Maybe in the chat, if you have access, if you want to put in, if somebody is at a higher risk of heart disease, so like, the demographics, the patients who were in this trial were above 50, had a family history of heart disease, had smoking history, had high blood pressure, etc. So if the trial had 4,000 patients, how many of them that are already at high risk of heart disease should be on a statin? If anybody, I think I should be able to see chat, or maybe not, I'm not sure. But if later we can check, if you want to put some percentages you think that this percent of this population should be on the statin, well, what they found, I'll tell you, is that only 25%, so 1/4 of the eligible patients were on a statin, which is very sad. So we want our patients to be on the preventive medicines, right? Like, not everything has to be after the fact, that after you've had a heart attack, there's plenty of, a small ounce of prevention can go a long way. So in that theme, they found only 1/4 of patients were on statins. Now, having said that, then they looked at a stratified analysis where what they looked is among patients who had the JAK inhibitor arm versus the TNF inhibitor arm, but then also looked at if you were on a statin or not. And guess what? The results change dramatically. Among the patients who were at high risk of heart disease already, but were on a statin for prevention, there was no difference between what drug you were taking. And the only difference in these events were coming up in that subgroup that was not on a statin. So at this point, of course, I'm left after that abstract was presented wondering, that is that the drug, that JAK inhibitor, that's the bad arm, or is it really the fact that these patients weren't necessarily doing preventive strategies that they could have been on because of, maybe their doctor should have mentioned this, and etc. So we'll leave you with that food for thought on this abstract. But ultimately, prevention is key. And if you are eligible and your heart, there's a high risk of cardiovascular disease, or your cholesterol is high, and statin is something you're eligible for, something to discuss with your doctor maybe tomorrow. Next slide, please, Nick. So now I will shift gear. So we talked about the lungs so far. We've talked about inflammation and gout. Now I'm going to shift gear to a very pragmatic, very practical question I get asked a lot. So I thought I will share with the audience today, is about COVID booster, right? So we are thankfully on the very good side of the pandemic now, and recovering and building up. But the questions I still get asked is, Dr. Singh, I'm gonna get my COVID vaccine booster, and should I be holding my XYZ drug that I'm on for my rheumatoid arthritis, or for my psoriatic arthritis, for my ankylosing spondylitis? And of course, where do I go back in terms of my resource to give answers is the ACR guideline. And if you've might have looked at these guidelines that the American College of Rheumatology has put out, some of them have a big asterisk to say this is based on expert opinion, and there isn't necessarily a trial data or a big study guiding our recommendation. These are my expert opinions, or whoever was in the room making those guidelines. Now, this trial, or this study abstract that I'm talking to you about, if you wanted to look it up, it's called the COVER trial, COVER. It was headed by Dr. Jeff Curtis at the University of Alabama in Birmingham. What they really did was they took patients with rheumatoid arthritis and spondyloarthropathy. So what does the SPA, the second, disease group here entails, is all patients with like axial spondyloarthritis, ankylosing, psoriatic, etc. They took these patients, and it was really a matter of people were already coming in. They were planning to get their COVID boosters, and they had their primary series of the 2 vaccines with mRNA vaccine. And now their question was, they randomized them. One arm was told to not stop your medication for two weeks after the booster vaccination. This other arm was told to stop your medication for 2 weeks. And really, they, at the end of the follow-up, they looked at the patients who had stopped versus not, and did they really have a vaccine difference in response to the vaccine. And really interesting, oh, by the way, the drugs they were looking at, what were the drugs? There were 4 classes of drugs. So not everything is covered, but among the drug classes, we really have low evidence as before we went into this trial were the TNF inhibitors, which is, adalimumab, Enbrel, infliximab, and those classes, abatacept, which is also goes by Orencia, interleukin-17 inhibitor, which is something like Cosentyx or secukinumab, and JAK inhibitors. And what they found were among patients who stopped these drugs for 2 weeks after vaccination, really, it did not make a difference. They did not get more efficacy from their vaccination. But instead, guess what? What happens when you stop your drugs? You flare. So, of course, the patients who stopped the arm that was randomized to stop the drugs, they flared. I think the flare rates were about 30% or higher, I think, in the arm that had stopped them. So that's something to keep in mind. Hopefully next time if you're on one of these drugs and you were wondering, I'm going to get my vaccine, should I stop my drug or should I not stop my drug? I hope you have the answer. There's no benefit in stopping these biologic drugs. Really, the one drug we have very good evidence to stop for your booster vaccination or vaccination in general is methotrexate. So 2 weeks of holding your drug post-vaccination is the one that you want to hold for is methotrexate. And my last slide, Nick, thank you for, yeah. So the one, now I will shift gear to psoriatic arthritis. And one thing I will tell you is that, sometimes you're at the ACR and there's 2 or 3 things that are, you walk away from the meeting and 2 or 3 things that are boiling in your head because they were just everywhere. So the one thing that I think was among the 2 things that were in my head stuck after I left the ACR 2024, one has been covered by Dr. Gardner, which was CAR T cell therapy. So, like the rains we are having sometimes in April and May everywhere, like how mushrooms grow after those rains. So that's what I felt about the CAR T cell therapy, is like they were everywhere like mushrooms at the ACR 24. But then the other thing that left an impression was this drug bimekizumab. And yeah, you'll have to say it 5 times before you can say it like I'm saying, because that's what I did. Bimekizumab. Okay, so what is it? Bimekizumab is an interleukin-17 inhibitor. It has a bit more coverage than the Cosentyx, which is already an approved drug for psoriatic arthritis in the market, but it is the one we have already, which is secukinumab, is interleukin-17A inhibitor. Bimekizumab has a bit more broader coverage of interleukin-17A and interleukin-17F. So with that in mind, there were several trials now, phase 3, that have been published, and it's been approved drug for this arthritis and other indications as well. But the idea was they looked at not just, of course, a lot of our arthritis trials have how many joints were swollen, if you have psoriatic arthritis, your skin, etc. But the good thing about this trial that they also looked at was really the things that sometimes I am struggling, because I feel in the clinic they are doing great. Their psoriatic arthritis is great. And then I'm looking some of the forms my patient has filled in during intake, and I see a lot of not doing well, or things are not great because they're either reporting pain still or fatigue, right? So what this analysis looked at and reported on was the impact of bimekizumab on pain and fatigue. And they presented different boiled down trial data from different duration. So there was a 52-week, which is 1 year, as well as a 2-year look at the efficacy of this drug. So 52 weeks and 104 weeks. And really, it did have a much statistically significant reduction in both pain and fatigue. It doesn't matter whether you took it compared to the placebo arm or compared to the TNF inhibitor adalimumab arm. The drug was really doing well in controlling these 2 symptoms, in addition to the arthritis and the psoriasis. So leaving you with a very positive note with bimekizumab in psoriatic arthritis. And I believe I pass it on to my very good friend, Dr. Bauer. Take it away, Dr. Bauer.
Thank
Thank you,
you,
Dr. Bauer.
Dr. Singh. Do you want me just to jump in, Nick? I can do it.
Take it away, Dr. Bauer.
All right, yes, we'll keep people moving here. Hopefully people are still awake. So I'm going to talk again about 2 big topics like Dr. Singh mentioned, but I think some exciting updates have happened over the last year or so. If you want to go to the next slide. All right, so in terms of lupus nephritis, just as a kind of a quick background reminder, lupus nephritis is something that can happen to patients with lupus. It certainly doesn't happen to everybody, but it's not an uncommon condition and something that we do treat a little bit differently than run-of-the-mill lupus that doesn't affect the kidneys and is something that we're screening for extremely regularly. Those of our patients with lupus are probably used to getting very frequent blood work and urine testing to try to look out for this. And then if there are any concerns that something might suggest lupus nephritis, getting a kidney biopsy, which is what these beautiful pink and purple pictures are. These are slides from the pathologists that are looking at different types of lupus nephritis. We can go to the next slide. So, one of the main things that we saw at ACR in terms of lupus was an update on guidelines for how we treat lupus nephritis. And there's a lot of words on this picture and a lot of abbreviations. The gist of it is just there's a few changes to how we're supposed to manage lupus nephritis. And this is, again, after we have confirmed lupus nephritis, typically having a biopsy, we diagnosed it, we have all the relevant labs. The main differences from what our previous recommendations were is a much faster taper off of prednisone. A lot of patients are familiar with prednisone to treat a whole variety of different rheumatologic conditions and really know the blessing and the curse that that medication is. And one of the main themes for me around ACR was learning more and more that we really need to be doing our best to get people off prednisone for whatever the condition is a little bit faster. And this is true for lupus nephritis too. So they're giving us a little bit more strict guidelines on how to taper the steroids off, and really with the goal to be on less than 5 milligrams by that 6-month mark. The other main update we have for these guidelines are the two newer medications for lupus, belimumab, which is also called Benlysta, and voclosporin. So these are newer on the market for lupus nephritis in the last 5 years or so. And so we're now trying to figure out, well, how and when do we use these medicines, since they weren't even around the last time we got new lupus nephritis guidelines. So they've come up with this concept of triple therapy, which is a phrase that those of you who have rheumatoid arthritis or are well-versed in the data there might be familiar with, because that's what we used to call, or I guess we still call, but that's what we call being on the 3 different kind of typical conventional medications for RA. And so they've borrowed that terminology and are applying this to lupus nephritis and saying that pretty much right off the bat, we should be a little more aggressive than many of us have been in treating lupus nephritis. So steroids, one of these newer medications, hydroxychloroquine, and then potentially mycophenolate, which is also called Cellcept. The other update here is that for the first time, the American College of Rheumatology included children and adolescents when they were thinking about their guidelines. So for those of you who may have kids as part of your involvement in the Arthritis Foundation or were diagnosed with lupus earlier, this is obviously very nice that we're also taking into account the needs of our pediatric population. Next slide, please. A few other kind of more, generic updates as part of the guidelines here is about screening. I don't think anything is super different here from what we were typically doing, but just to remind us that we really should be screening when we know someone has lupus, systemic lupus. We should be checking frequently, at least every 6 months, or if there's other signs of a flare, to check for proteinuria, which is typically a urine test. Next. Click. This tells us when to do a biopsy. So again, nothing super different here, but just really reminding us that when people have more than 0.5 grams of protein in their urine, we should have a serious discussion about the risks and benefits of doing a kidney biopsy. And that if people have had a diagnosis of lupus nephritis and now there's some signs that they are having a flare, or if they've been on treatment that we should be adequate but aren't responding appropriately, then that's another good time to think about doing another biopsy. Some recommendations here for monitoring. So after we think we've gotten people into remission in terms of their lupus nephritis, we should still be doing blood work and urine every 3 months to make sure that people are staying in remission. And I think there's one more, if you click it. We'll see. Oh, yes. And then this is a little bit of guidelines around when to think about dialysis. So obviously, one of our main goals in treating lupus nephritis is to avoid the need for dialysis, but it certainly is a life-saving measure when needed. So the guidelines here suggest that we actually think about kidney transplantation over dialysis if time allows. So that is just something for us to keep in mind. Obviously, another big decision, kidney transplant, not necessarily something you can just do overnight, but to encourage us as rheumatologists to really be thinking about that option. And then to really start that discussion earlier than maybe we're doing and thinking about that if it looks like things are heading in the wrong direction, since we can't exactly do that too super quickly. Next slide, please. So just to kind of quickly summarize this in a little bit more friendly fashion, in terms of updates for lupus and screening, we're going to be doing pretty frequent checks for overall lupus activity, but in particular, making sure we're monitoring the kidney function. Sometimes we're going to need to go ahead with a biopsy to really know for sure what's going on and to help us guide our treatment. And then if things are heading in the wrong direction, that maybe a transplant is actually the best thing rather than heading right to dialysis. Next slide. All right. And then Nick was worried that this was too many words for a slide, which I agree. It does look very busy, but this is just to say that nothing is ever easy in rheumatology, and our nephrology colleagues, our kidney doctor colleagues, they actually also came out with their own lupus nephritis guidelines this year, and they are different from our guidelines in rheumatology. So I just wanted to acknowledge that this is not set in stone in terms of how we treat lupus nephritis, and different doctors may be doing things different ways, and we're all doing things by our own guidelines. And I know, at least in my hospital, I often work very closely with a nephrologist, and we're talking together all the time, and we're coming up with decisions together. But some people may not have access to both a rheumatologist and a nephrologist, and maybe one is treating one thing and the other is treating the other. And so there might be a little bit of discussion about this, and I think it's totally fair to ask your doctor which guidelines they're following. All right, next slide. All right, so I went to a really interesting panel discussion at ACR this year that has prompted me to do a lot more research. So this wasn't a specific publication or poster, but there was a really nice talk by 3 different rheumatologists on the importance of sleep in rheumatic disease. And I think if you just Google that plus ACR, these doctors tend to give a lot of talks online, and they have a few different recordings, although not necessarily from the ACR. But they presented on the fact that, as a lot of us can imagine, getting good sleep is super important for everybody, but especially for people who have autoimmune disease. And they were able to quantify this a little bit, especially in lupus. I pulled out those numbers for the purpose of this talk. And a quarter of patients with lupus have signs of sleep apnea, and a quarter of patients will get restless leg syndrome. And these are 2 things that we can often intervene upon and treat to some degree. And so if there are things that are affecting our sleep that are fixable, we should really be letting our doctors know about them so that they can help out with part of that. And there's a lot of different things that treating our sleep can help with. So, one thought is active inflammation affects our circadian rhythm and our sleep cycle. Some of the medicines that we use in rheumatology, like prednisone, can directly affect sleep in that way. And then being in pain can affect sleep as well, of course, getting comfortable. So there's a lot of different parts to this equation. And they don't always have to be sleep-related medications. There are things like cognitive behavioral therapy, really focusing on sleep hygiene and exercise at the right time of day that have actually been shown to improve sleep. So I thought I would highlight that. Next slide. All right, so this is a quick pivot to vasculitis. I only have one topic for vasculitis here. I wanted to make sure that those of you who have vasculitis or know somebody with vasculitis were aware of some of these kind of big updates in giant cell arteritis, GCA. This is a type of large vessel vasculitis that tends to affect older people. This is where you get pretty significant headaches and some pain when you're chewing, tenderness over the scalp, achy pain in the shoulders and hips, and it can actually cause blindness if it's not treated quickly. And historically, we have not really had a lot of great treatments for this aside from high doses of prednisone for a very long time. And about 6 or 7 years ago, we got a new medicine that was approved called tocilizumab for this, which has really changed things. And then now we have this really interesting study looking at a JAK inhibitor, upadacitinib, looking at giant cell arteritis as well. And so the gist of this is a really interesting, promising study that showed that they could avoid flares of GCA. They could get people off prednisone much faster than we typically do with this medication. And next slide. I think we left off one slide, which was the point that this actually got FDA approved for GCA just last month. And so this is not just something that got presented at ACR. This actually is now something that's part of our armamentarium in rheumatology. And so you might actually be able to take this. So, all right, thank you.
Fantastic. Thank you so much. Now it's time to welcome Dr. Doohan.
Great, thank you. I really appreciate the invitation to be a part of this great panel to talk about some of the great information and data and discoveries that come out of this annual meeting every year. My name is Kori Doohan. I'm a rheumatology nurse practitioner at the University of Washington. I also am a professor within the University of Washington School of Nursing. I've been in rheumatology for over 2 decades now. Next slide. In addition to being a nurse practitioner, I'm also a past president of the Association of Rheumatology Professionals. It's a bit confusing, so I wanted to really kind of clear up the differences between ARP and ACR, since we've talked a lot about ACR today. Really, ARP represents this wide range of professionals that are all part of ACR, but we are our own division. So we make up about 18% of the total ACR membership umbrella. And in fact, that's why I colored about 18% of this umbrella as red. We're that portion of the whole ACR membership. We really encompass a wide range of professionals within the rheumatology team, including physical therapy, occupational therapists, psychologists, social workers, nurse practitioners like myself, PAs, nurses, and even our PhD scientists. And as a result, you can imagine the research done by this diverse group of professionals is unique and especially relevant to the patient experience. So I'll be sharing a couple of studies that were presented at our last national conference, which I found interesting. I used a little bit different format than the rest of our speakers today. And that's just because of my experience. What I really love about attending this meeting every year, I love going to the programs and listening to the speakers. But what I really find fun is wandering the poster hall. The poster hall at this meeting is incredible. You have hundreds and hundreds of posters up on the wall with the people, the researchers who've been putting their life energies into this research for the years prior. In front of their posters, they're answering questions. And there's just so much information sharing that happens in this very dynamic experience. So I could have shared, 100 different posters with you today from our ARP membership specifically, but I chose just a couple just to give you a little bit of a flavor of the types of things that we get to enjoy when we attend this meeting every year. So next slide. So the first study I'd like to present is the results from the Canadian Early Arthritis Cohort Study. This was done by Dr. Susan Bartlett at McGill University and colleagues. This study examined the relationship between mental health and response to treatment in patients who are newly diagnosed with rheumatoid arthritis. Anxiety, depression, and fatigue are very common in rheumatoid arthritis patients, and this study specifically aimed to quantify how these symptoms impact rheumatoid arthritis or RA response to treatment. The next slide. So these graphs show an interesting story, and I want to go through this a little bit. So if you could look on the left-hand side, the first graph that's titled CDAI, S-C-D-A-I. CDAI is a disease activity measurement score. So the higher the number, the more active or severe disease you have present. And what this graph is showing is patients who are newly diagnosed with rheumatoid arthritis at baseline, and then a point at 3 months and a point at 6 months, and what their disease activity scores show. And what's good is we're treating their rheumatoid arthritis. You see a decrease in the CDAI as expected as we're treating them. But what I really think is interesting here is when you look at the difference in baseline mental health. So those that have the red line, they have more moderate or severe symptoms of pain, anxiety, depression, and fatigue. And so you see that they start out very high. And even though they improve, they really only get to almost just a basic starting point of those patients who started out with minimal pain, anxiety, depression, and fatigue. So it's very interesting that minimal group is the group in blue. So you can see that, interestingly, where you are with your mental health makes an impact in how you're going to respond to therapy and to what degree. The same is shown in the other two graphs next to it. So physical function, as the physical function increases, the number goes up, and that's better. So again, you can see the lowest group, those with the lowest physical function were those patients at baseline who had the most pain and anxiety, depression, and fatigue. And their number went up a little bit over the 6 month period of time in a similar fashion as those who had minimal, the blue line. They started out at a higher level, they increased as well, but you can see how dramatically the underlying uncontrolled anxiety, depression, fatigue symptoms, those mental health symptoms, how they impact the trajectory of disease. And finally, the last graph shows social participation, and this is through a questionnaire. And so those patients who had the most anxiety, the most mental health issues, they were in red again, and they had the lowest social participation. And though there was improvement with treatment of their rheumatoid arthritis, it really was very much impacted by these mental health aspects. Next slide. So what this study shows is really not a surprise to those of us who work in rheumatology. And high pain, anxiety, depression, and fatigue at diagnosis are linked to worse rheumatoid arthritis outcomes. It really is a call to action, however, for patients and healthcare providers to do a better job assessing for and especially treating those mental health symptoms. We should be as aggressive with our mental health treatments as we are with our disease-modifying anti-rheumatic drugs in order to achieve better outcomes for our patients. And I think this is a key that comes out of this study. Next slide. All right, so this was another poster that I saw. The second study I'm presenting is from Dr. Thomas Bai and colleagues, and has to do with understanding the role of physical activity in patients with knee osteoarthritis. So knee osteoarthritis causes pain and limits really the mobility of the knee joints. It impacts physical function. It's very common, especially as we age. Physical therapy, Dr. Bai is a physical therapist. Physical therapy is a mainstay of treatment for knee OA, but relief is often limited. This group of physical therapy researchers really wanted to know if modifying daily behaviors, such as time spent sitting and standing, may be an additional treatment to improve physical function. So the participants in this study were involved in a 12-week traditional kind of physical therapy program, but they also wore special accelerometers while they were at home to measure their non-exercise daily behaviors. And what they found is that the more overall physical activity in these non-exercise daily behaviors was linked to better physical function in people with knee OA over time. Next slide. So what I thought what was really truly unique about this study was how it was performed. So this picture on the left shows they placed sensors on participants at the waist and at the thigh to measure what had not previously been considered physical activity per se. This included things like light stepping or inactive standing or even active sitting. And active sitting, I got clarification, meant like doing something while you were sitting. Maybe it was, folding laundry. So they found that even the most basic increase in activity, so not being a couch potato, but doing something when sitting on the couch or puttering around, as I like to call it, resulted in improvement over the study period. So next slide. So really, even those activities we don't necessarily think of as exercise or physical therapy are vitally important in improvement in physical function and reduction in pain. Really just keep moving. So it reminded me of the Martin Luther King Jr. quote that you've probably heard, which is, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forward. All right, thank you. Those are my slides.
All right. We did have a couple of questions in the chat. The first, I'll start with Dr. Dada. It was a question about pseudo-gout and the difference between pseudo-gout and traditional gout.
Yeah, thank you. Good question. So gout, as I explained, is high levels of uric acid in the blood that form these dagger-shaped crystals, end up in the joint. People know they have gout when they feel like their foot got hit by a hammer. and then they have that excruciating pain. That's gout. Something that looks like gout is called pseudogout, and that is when calcium buildup happens in the joint. Multiple reasons why that can happen. Sometimes it's because your thyroid or maybe your parathyroid gland are not really handling the calcium like they should, and it ends up being deposited in the joints. And so, but the pain, anytime your body notices that there are crystals, whether it's calcium crystals or uric acid crystals, your body sends a bunch of white cells to attack it, try to engulf it, and that is the pain that people experience. So pseudogout is calcium deposit, looks like gout, feels like gout, hence it's pseudogout. But the treatment is totally different, as you imagine, because there are two different things being deposited in the joint. I hope that helps.
Great, thanks so much. We also had a comment when Dr. Singh talked about the benefits of statins for people with rheumatoid arthritis. There was also a comment about the use of a Repatha shot. Do you have any guidance on that versus a statin?
No, I don't. I think that might be stretching it a little beyond the rheumatologist's expertise. But I think what I would say is as long as they are on some preventative therapy and controlling their high cholesterol levels, that's the key. So I don't think beyond that would be, unless there is a question under, in that comment, I'm
Sure.
happy to address. But I think I would say very happy that whoever, the person is on preventive treatment.
Thank you for that answer. Next, the question was, does interstitial lung disease or ILD ever occur in psoriatic arthritis?
Yeah, great question. It does not. You can occasionally get lung fibrosis in the upper part of the lungs with a disease that's a cousin called ankylosing spondylitis, but not with psoriatic arthritis. So yeah, good question. No, psoriatic arthritis does not typically affect the lungs.
Excellent. I have a question for Dr. Bauer, a question that we get often from our patients related to a dilemma that your slides brought up. Often they are working with multiple healthcare providers. They have providers that may have differing opinions on a treatment, and they are in crossroads as far as what type of decision they should make about their treatment. How can patients prepare themselves, and how can they use what questions can they ask healthcare providers about getting guidance on the best treatment pathway?
Gosh, that's a really good question. I think definitely a challenge, especially if you might have different clinicians at different institutions, and we've all experienced how challenging it can be to have everybody on the same page. I think a lot of institutions, and in particular with rheumatologists, we're rheumatologists because we love collaborating with other specialties. And so many of us will have multidisciplinary boards or panels where we get together with the specific intention to meet and to discuss that. And so that might be one helpful way to see if that's sort of the culture of your institution. But I think you're right. I mean, I think it's probably very helpful to pick the clinician that you get along with the best and that you have the best communication with, and really ask them to be your advocate and to be your cheerleader and to maybe include you in some of the conversation. I think a lot of the time as physicians and clinicians, we're doing a lot of coordination behind the scenes, and maybe the patient isn't seeing that happen because we're talking back and forth through the electronic medical record. And so if that is something you're wondering about and it's just not visible to you, it's totally reasonable to ask, have you discussed this with so-and-so, or are they aware? This is what my understanding is. What is their understanding? I usually make a point when I come into a patient room, and I've spent usually at least 5, sometimes 10 or 20 minutes looking through the chart already, seeing who they've seen in the last 3 months, what the other labs show. And I try to give a little summary, we saw each other in November. It looks like since then you've seen Dr. So-and-so and Dr. So-and-so, and you had this test done and that test done, and you started this medicine. What other updates do you have for me? So if you're getting the sense that maybe there's something happening that your rheumatologist or nephrologist or primary care doctor is missing, also feel free to chip in and just make sure that everybody is on the same page. But I think it is a challenge, especially for our rheumatology patients who can have easily 5 or 6 different clinicians at different places.
I will add a question. A lot of patients are very nervous, some even skeptical about some of the medications and treatments that are available nowadays for people with arthritis. What would you say to those folks that are nervous about a new treatment for their autoimmune disease?
Yeah, I think that is definitely a common thing that I hear from my patients is a little bit of hesitation. I think it's helpful if you can voice what your concern is, because maybe it's something that we can actually very easily point to the data that we have. The other thing in rheumatology is it's pretty common for us to borrow medications that have been actually around for many years prior to it making to us and other diseases. A lot of our psoriatic arthritis medicines had been used in psoriasis for 5 or 10 years before it finally got approval. And so maybe there is a lot more data and safety data out there than we're aware of when it looks like when you're just Googling, the indication for psoriasis. And so that can be helpful and reassuring. I think we also need to ask your rheumatologist where they find the best sources of information are for you, so that you make sure when you're doing your own research, at least it's coming from a place where we think has good information. The American College of Rheumatology has a great website. The Arthritis Foundation has a great website that tries to collect some of that data. I know there's a lot of other different patient support groups out there, and I think some are a little bit more robust than others in terms of the information that could be helpful. But yeah, I think at the end, they just sharing with your rheumatologist what your specific concerns are so that they can address them. And for a lot of my patients as well, I talk to them, I send them information, and then we also have a pharmacist who's available to have another discussion with them. We have a rheumatology nurse who's available to have another discussion with them. So you shouldn't feel like you're need to get it from one person in the doctor's office. We now have really great teams, and everybody can more than happy to give you the same spiel again, again, and again until you're comfortable.
Great. Thank you so much. I have a couple more questions coming in here. One is on osteoarthritis treatments. This is something I'm just now hearing a lot of chatter about, and that is low-dose radiation therapy. Does anyone have any thoughts on this?
As it turned out, I was at the clinic yesterday, and one of my patients had signed up for low-dose radiation therapy for their hand osteoarthritis. So I actually looked up the literature. I'm not, we don't, we're a little worried about radiation therapy in the US. And in Europe, they're a little bit more relaxed about it. So the data that comes to us is suggestive that it may be somewhat useful. As low dose radiation, there's been mixed reports. And so I'm going to have this patient give it a try, because nothing I've done so far has given her the relief that she needs. So based on that, we're going to have her try it. She's been reassured that, it's relatively safe at the low dose she's going to get, and we'll see if it works. So I don't have a lot of experience with it. I've used it for some recalcitrant heel pain in a patient with ankylosing spondylitis in the past, but this is the first time I'm going to use it for osteoarthritis. So, but what I read from my little AI program was that the literature is mixed, and there is some evidence that is beneficial, and that comes from Europe, where they tend to be less concerned about radiation than we are here.
Thank you so much for that honest answer. The next question was about the risk of high cholesterol from Rinvoq, and are there alternatives to statins?
Happy to take that. I think that's a great question. Just so you know, the oral surveillance trial I was referring to in my first abstract studied its cousin, the tofacitinib. And Rinvoq is, in the same class, the JAK inhibitors. The one thing about in terms of cholesterol increase, I mean, that's real. It can bump up the LDL, which we call it as, more simpler terms, the bad cholesterol, but it also bumps up your HDL, which we also call as the good cholesterol. So at the end of the day, the ratio of your LDL to HDL stays stable. So it's not like only your bad cholesterol is increasing. There's some increase in your good cholesterol as well. Ultimately, of course, at the end of the day, what we worry about is, will this translate to more heart attack, right? Like, that's the net question of by my bad cholesterol increasing. So far, I think I will admit the data on Rinvoq is rather limited compared to Xeljanz, but so far the data has not shown that it translates to more heart attacks or other cardiac events. So good news in that sense. So that was the first part about how about Rinvoq and high cholesterol. So it happens, but usually within first 12 weeks of taking it, and ultimately we don't think it translates to cardiac events. Now the question of alternative to statin, I think the good news is this question is asked is being asked in May of 2025. If it was during my med school times, I would say, no, there are no alternatives. But yeah, yay, we are in 2025. Seems like cardiologists have made leaps and bounds of progress. And, one of our friendly audience member had mentioned about Repatha, which is the PSCK9 inhibitor. And these drugs are being used commonly now as well for lowering of cholesterol. I think at the end of the day, cannot diminish the role of diet and lifestyle interventions at the same time. But if you were looking at more pharmacologic, I believe there is another new class of drugs that it's escaping my mind. But I promise you, there's besides the PSCK9 inhibitors, diet, lifestyle. And then I think the one other I can double check and put it in the chat. I think there's a newer class
Well,
in addition to those.
well, you opened a door into a question that came up in the chat, and
Oh.
that's the number one question we get at the Arthritis Foundation that we did not address today, and that is the role of diet and gut health. So
Absolutely.
do you want to add anything to that, or does any of the panel want to share?
I can
Sure,
stop
please.
talking or maybe I'll give my one liner and
Okay.
then go on, let other panelists take over. I was honored to be part of the ACR's lifestyle and nutrition, guidelines for management of rheumatic diseases. And I participated as the voting panel as well as the lit review part of it. And at the end of the day, I think if you were to ask me specifically in rheumatic diseases, the data for exactly what diet you should follow is limited, but we are borrowing from the American Heart Association to say that the best evidence right now is for the Mediterranean diet in terms of, and that's what was endorsed in the ACR guidelines for nutrition. But with that, I will pause and see if anybody else wants to give their thoughts on this.
Well, in past ACRs, we've had sessions on the microbiome, which is what bacteria are in your intestine. And we know that sometimes can influence the levels of inflammation. Didn't have a session this year, but in past, people have talked about certain dietary manipulations, at least in animal models, that have actually impacted inflammation in animal models of arthritis. We haven't quite figured out how to manipulate the intestinal bacteria in humans to any significant degree at the current time, but at some point we may have more information on how to do that and do it effectively, and that may become part of our sound regimen of medications and a certain probiotic that may actually impact bacteria in the gut in a special way. We do know that animal product heavy diets tend to foster bacteria that are more likely to cause inflammation. And you can see why that might be so, is because in the past, when those things were not very clean, or your body had to produce more inflammation to make sure that they didn't cause problems. But in general, I think we're at a point now where we're interested, we're moving forward. We don't have any firm recommendations yet for patients, except to consider doing those lifestyle things that actually will lower your cholesterol, which is also probably good for your gut health as well. Anyway, that's my 2 cents worth.
We did have a quick question on how long should you delay your methotrexate before a COVID vaccine or booster?
Yes, I'm glad you asked. A question it's almost as if I planted that question, but I did not. 2 weeks.
2 weeks. 2 weeks. Awesome. Great. And the last question was about, again, managing multiple forms of arthritis, and how do physicians and patients make decisions about a treatment plan if they have multiple forms of arthritis?
I can go ahead and answer that, because I'm frequently asked to kind of navigate these questions for patients. Honestly, so it was alluded to earlier, sometimes we use medications to treat one autoimmune disease, and it may also have benefits in treating another autoimmune disease. So that's one way to think about it. There is a lot of overlap between autoimmune diseases. Sometimes our treatment choices are based on what symptoms are the most bothersome, and so we'll focus our treatment towards those specific symptoms. And then I guess the other thing that I would say is that we do have these guidelines that we've talked about, and many of the guidelines do talk about some of these unusual comorbidities, or why you might use one therapy over another in a certain situation. So that tends to be how we address it.
The thing that often happens is our patients with rheumatoid arthritis will often have osteoarthritis at the same time.
Mhm.
And therefore, we do have to take that into account. And It also, it helps or may have rheumatoid arthritis, osteoarthritis, and fibromyalgia. And that really does take a very thoughtful approach. And I know my colleagues here, we deal with that on a regular basis. And we have to actually educate the patient as to which one of these things is likely to be causing your current problem, and then try to address that. A lot of times when people have pain, I've noticed that autoimmune disease is often the first thing that gets blamed, but there's other potential causes of pain, and we need to address and be holistic about approaching our patients and think about them as a whole person, not just as an autoimmune disease. What I've always appreciated about Kori and her colleagues is nurses do take a very holistic approach to patients, and I've tried to learn from them that way of thinking.
Well, I really appreciate this panel answering so many terrific questions and all of the presentations that they've given today. Just want to run through a couple of quick resources from the Arthritis Foundation and from ACR to help wrap up this presentation. So first is, if you have questions that weren't answered today, or you have questions about your arthritis, your insurance, better understanding your disease, want to get it connected with community exercise programs, you can call our helpline at 1-800-283-7800 or email at helpline@arthritis.org. Trained staff can help you navigate these questions. Please note that the questions are available in English and Spanish, and also have access to a number of translation services. We have other great, fantastic webinars coming up. We have one typically a month. In June, we will be discussing your back and arthritis, and in July, we will be discussing physical activity and movement with arthritis. You can always go to arthritis.org/webinars to register for these free events. A special thank you to our Connect Your community for tuning into this webinar today. If you are watching this webinar on YouTube or on the arthritisfoundation.org website, please check out our Connect groups. These are support groups, peer-led groups for people just like you. There are more than 65 groups that meet just about every day of the month. We have upcoming group meetings on chronic pain, psoriatic arthritis, and newly diagnosed. But again, we have lots of different groups and lots of different topics that meet both online and in the community. Go to connectgroups.arthritis.org. The ACR has outstanding resources as well. You can check them out at rheumatology.org. You can help find a rheumatologist, get information about your disease and treatment, and get involved in their patient advocacy program called Simple Tasks. It's outstanding. And lastly, May is Arthritis Awareness Month. Please know that we see you, and arthritis is a very important health condition that we need to shine a light on and make greater awareness about the pain and disability of arthritis, and fight to shine a great light on the outstanding providers and science and research that happens all throughout the year. I want to really thank